Hello and welcome to On the Edge, Conversations in Internal Medicine. I'm Dr. Jonas Moses, and this hour we are going to be talking about multiple myeloma. Multiple myeloma is part of a broad group of diseases called hematological malignancies. With me this hour, and I'll introduce him in just a second, is Dr. Doron Feinsilber, my regular special correspondent to On the Edge in internal medicine. Multiple myelomas, also known as myeloma, plasma cell myeloma, or Kehler's disease after Otto Kehler. And it's a type of cancer of plasma cells, which are immune cells in bone marrow that produce antibodies. Myeloma is regarded as incurable, but remissions can be induced with steroids, chemotherapy, thalidomide, and stem cell transplants. Just a little bit about the epidemiology of multiple myeloma. In the United States, according to the American Cancer Society, there are 40,000 people living with multiple myeloma, and they estimate that approximately 14,600 new cases of myeloma are diagnosed each year in the U.S. alone. It follows from here that the average survival in all diagnosis is about 3 years. Multiple myeloma is the second most prevalent blood cancer, 10%, after non-Hodgkin's lymphoma. It represents approximately 1% of all cancers and 2% of all cancer deaths. Although the peak age of onset of multiple myeloma is 65 years to 70 years of age, recent statistics indicate both increasing incidence and earlier age onset. Multiple myeloma affects slightly more men than women. African Americans and Native Pacific Islanders have the highest reported incidence of this disease in the United States, and Asian is the lowest incident population. Results of a recent study found the incidence of myeloma to be 9.5 cases per 100,000 African Americans and 4.1 cases per 100,000 Caucasian Americans. Among African Americans, multiple myeloma is one of the top leading causes of cancer death. Before I go into a little more disease process here, I do want to formally introduce Dr. Doron Feinsilber. Thank you so much, as always, for joining us.
Pleasure to be here.
And this may be your last official visit with us for some time. Doron, you are moving off to Baltimore to work at a Johns Hopkins Associated Hospital. And tell us a little bit about that, because I'd like for my viewers to recall what your background is.
Well, my background is mostly in internal medicine, and I spent some time this past year doing some imaging work and decided to follow my pathway back into internal medicine and to get certified as well in medical oncology, and that's why what we're talking about today is just up my alley, because I've even had people personally be affected by diseases by like multiple myeloma. In fact, we had a close family friend from growing up that had passed away suddenly from that, and I felt that I would like to even dedicate part of the show, towards his memory and towards the Multiple Myeloma Foundation that we'll talk about a little bit later.
Good. All right.
But that's true that I will be switching gears and moving off to Baltimore in another month or so, and hopefully we'll see if I can squeeze in some more time, with you lovely people here at On the Edge. But hopefully. There'll be a good correspondence from there, and I'll be able to contribute, my knowledge base towards the medical public. So
make sure that happens. And recently, you had some additional certifications. Is that not true?
Well, I just recently sat for my my full licensing board exams about 2 weeks ago. A lot of us docs have to go through all these fun tests. It was 16 hours of testing in front of a computer.
And then you also recently, I believe, a diagnostic certification?
Well, I'm also applying for licensure to administer therapies that require some radioactivity. I took some certification courses in that about 2 months ago or so that are regulated by the Nuclear Regulatory Commission. And I think in fact, we had a show that talked about Zevalin and Bexar, which were therapies used for non-Hodgkin's lymphoma, that target the CD20 positive marker, and these are antibodies that are labeled with I-131 and Y90, and in order to give those medications out, you have to be a licensed physician and to have a permit to give radioactive isotopes. So that's a little side project. But
Great. Now, there is, we're going to move on and talk a little bit about the signs and symptoms. There is a mnemonic that's used, CRAB, calcium, renal failure, anemia, bone lesions, that's used to recall some of the associated symptoms and signs. Can you speak to these findings?
Yeah. Well, I think before we go into that mnemonic, it's important to understand, again, before we take the humanistic element of the disease, and before we actually talk about the clinical aspect, we have to understand the pathophysiology behind it. Why does that work? What's the basis of this disease? And as you mentioned, this is the second most prevalent blood cancer, after non-Hodgkin's lymphoma. Now, multiple myeloma, interestingly enough, here's actually how this works. You have these precursor plasma cells in the spleen. You also have precursor cells in the bone marrow. And these plasma cells have to do with immunological memory. And if we go back and talk a little bit about our basic knowledge of immunology, here's what happens. When you have your humoral-mediated immunity, so your antibody-mediated immunity, you have to have cells actually remember being exposed to a certain foreign antigen or protein, whether it's polio or what have you. Every time that if you get a vaccine, you're creating memory B cells that can reproduce should your body be exposed to that agent again, and those cells will be switched and start making antibodies against whatever that is. And
is that process well understood?
It's very well understood. And I'll talk about that a little bit later in the show, but that's a process called VDJ joining, which requires essentially, if you have a line of DNA and you have one side that's 5', the other side that's 3', what happens there is that you have constant looping and variations in the germline of the cell that make it very specific towards creating antibodies against that antigen. And the biochemistry of it is beautiful as to how that actually works and how specific that actually is. Multiple myeloma means that you actually have a cancer of those memory cells, of those plasma cells. And when it gets so out of control, and it goes into the bone marrow, that means that you are going to create a deficiency of progenitor cells that come out of the bone marrow. So in other words, things that make your red blood cells, those precursors, those are going to be gone. And that's how you become anemic, because the building blocks for creating these red blood cells are going to be gone. And that's actually how you get exposed to the other adverse conditions. Here's the other thing, is that when you have these plasma cells, remember, these plasma cells are just going out of control. They're constantly secreting antibodies that is basically creating junk, and it's going into your bloodstream. So the blood becomes very viscous. You feel like you're getting very slowed down. Clinically speaking, your sedimentation rate is going to be markedly elevated. It can affect your peripheral vision. Now, and I'll talk a little more about those symptoms as time goes on.
Okay, we are going to a commercial break. Stay with us. This hour we are talking about multiple myeloma. I'm Dr. Jonas Moses. You're watching On the Edge. And my guest this hour, Dr. Doron Feinsilber. We'll be right back.
Any questions?
No.
You know. We're not magicians, we can't read your mind.
We answer questions, each and every kind.
What are the side effects, doctor, doctor?
How many times have you done this before?
Questions are the answer.
Will this react with my other medicine?
Hey, what are all these tests even for? Every kind. Questions are the answer. Questions are the answer.
Welcome back to On the Edge. I'm Dr. Jonas Moses. This hour we are talking about multiple myeloma. My guest, special correspondent to internal medicine for On the Edge, Doron Feinsilber. Dr. Doron Feinsilber is an internal medicine physician. And right before the commercial break, we were preparing to talk about the signs and symptoms. I mentioned this mnemonic, calcium, renal failure, anemia, and bone lesions, CRAB, as it's called.
Right.
And do you want to pick up from there?
Sure.
All right.
So before the break, we talked a little bit about what the pathophysiology is of multiple myeloma, and just like the mnemonic states, I'll go through each one of those individually. So now, when you have an hyperproliferation of these plasma progenitor cells, then number one, you're going to have anemia because you are destroying all the precursor red blood cells there. That's one thing. Second thing is that you're also constantly secreting these junky antibodies that actually don't have any specificity towards anything, and that will eventually cause renal failure. So that these are called Benz-Jones proteins, and what happens is, or these are light chains, or they actually call them myeloma light chains. If we remember the structure of an antibody, you have one part that's, it's like a Y-shaped molecule, and the top part of the Y is what's called the constant region, and the little part that branches out like this, Jonas, is called the variable region, and that's actually the light chain of the antibody. So the light chain of the antibody will actually cause binding to the glomerular basement membrane in the kidneys. Okay, so if you actually look at the structure of it, what a nephron is, and you look at the actual glomerular capillary base, the antibody itself will bind to that part because of electrical charge. One part's negative, one part's positive. It goes together, and it will cause what's called a acute glomerulonephritis, or a type 3 hypersensitivity reaction. This is going to cause eventually renal failure, or acute renal failure, and that paradoxically makes the anemia even worse because erythropoietin is secreted from the kidney. So
let me ask you a question, Doron. Is this something that's peculiar to myeloma, or does this same kind of event take place in other disease processes?
It can happen in other diseases for sure, like a Goodpasture syndrome, for example. That's another disease, but that's more autoimmune in nature, where you actually have same thing. You have deposition in the basement membrane of the kidney, and that can happen too. But if you actually stain it if you actually look at it histologically, you actually get a linear pattern of IgG when you actually look at a kidney biopsy.
And IgG is immunoglobulin
gamma, correct. So there's a lot of other autoimmune diseases and other types that can actually cause that to happen. Essentially, anytime that you have an oversecretion of negatively charged particles or high molecular weight proteins going through the bloodstream that get filtered through the kidney, that's the type of response you're going to get. And so with multiple myeloma, that's exactly the case. So now back to your CRAB mnemonic, and actually I have to really say that's really an excellent mnemonic that you brought up. I think it gives a good basis for the viewing public to understand that. So you have renal failure, that's one thing. Now what happens when you have renal failure? It means that you have more anemia because the kidney itself is responsible for also stimulating red blood cells to be produced. The actual myeloma itself, interestingly enough, secretes two different cytokines. These are chemical signals, interleukin-1 and interleukin-6. Those two combined are actually going to work synergistically in the body on the osteoclasts in the bone and actually cause hypercalcemia to occur. The hypercalcemia, again, paradoxically, is going to hurt the kidneys as well. Everything cycles on itself. It's one of these diseases where you throw a wrench right into the machine, and the whole thing starts folding on itself. And so now you have hypercalcemia because of the cytokine-mediated response from the plasma cells that are not working properly. You get renal failure because you have deposition of these light chains in the basement membrane of the glomerulus in the kidney. And then at the same time, that when you have hypercalcemia, now you're going to have deposition of calcium in the kidney as well. That's going to even make that worse. And then as a third step, that means the clearance of the calcium is going to go down as well because the kidney is already starting to be dysfunctional. So that's a couple other things. Also, tumor necrosis factor alpha plays a role in the pathogenesis as well. And I think that'll be important to discuss a little bit later in the show that there are agents targeted specifically against TNF-alpha, that, and one is called thalidomide, that actually caused a lot of different limb anomalies in children in the 1960s when people didn't really know what it was for. But so that's one thing. So you have anemia, you have renal failure, you have hypercalcemia. I'll talk a little bit about the hypercalcemia and so why that's important as well. The hypercalcemia, first of all, if I go into the emergency room and I see a patient who is lethargic, his mental status change is very obvious. What happens is that you actually have the person creating almost like a dementia. Clinically, that person is going to be much worse off.
From the anemia?
No, not from the anemia, but from the combination of the cytokines working on the osteoclasts in the bone. Okay. Because remember, they have a balance between the calcium absorption and calcium reabsorption, and this creates an imbalance. And it's because of that, and also remember the high turnover rate of these cells too. Remember, I think we discussed in one show previously about tumor lysis syndrome. That's right. And you remember that was going to happen, that since you have a massive turnover of these cells that are not working properly. Okay, you're going to have a massive release of uric acid, and the calcium will go up as well. Phosphate's going to go down because it gets combined with the calcium, and then of course the potassium is going to go up very high, predispose you to arrhythmias in terms of a cardiology standpoint.
So you're going to see a plethora of these kinds of symptoms. And
you're going to see
point to
the pathophysiology of multiple myeloma is fascinating, but again, I think what I try to do a lot of times is try to explain why this happens, how we treat it clinically, but then lastly and most importantly is the human aspect, and that's what I think we'll address that a little bit later in the show. Good. But so that's basically what the crab mnemonic is talking about. That you're basically creating a situation where the kidneys aren't working, you have massive anemia, you have these Bence-Jones proteins that are being secreted, and creating more pathogenesis as well. So what we'll discuss in the next segment is a little bit about how this affects the body's immune system and how your ability to fight off disease. That's because that's a cause of mortality from this disease. And so I think we'll go from there.
We're going to take a commercial break. Stay with us. An intriguing hour. This hour, we are talking about multiple myeloma. I'm Dr. Jonas Moses. You're watching On the Edge. With me this hour, Dr. Doron Feinsilber. We'll be right back.
No matter where you live, life in the oceans depends on you. To keep our oceans clean, recycle and dispose of trash properly. To learn what you can do, go to keepoceansclean.org.
When someone abducts a child, they're not about to advertise it. But we will. Sign up at wirelessamberAlerts.org to get free Amber Alert text messages on your cell phone. Help put a child abductor out of business for good. Wireless Amber Alerts. A child is calling for help.
Okay.
Welcome back to On the Edge. Conversations in Internal Medicine. I'm Dr. Jonas Moses. With me this hour to talk about multiple myeloma, Dr. Doron Feinsilber. Doron, during the commercial break, we were starting to talk about IgG2A.
Right.
And just to remind everyone, IgG is immunogamma globulin. And tell us a little bit about the action.
Okay. Well, I'm going to take about one step back, give everybody a quick 1 minute immunology lesson. Good. And so here's the thing. When you first diagnose multiple myeloma, when a patient comes in not feeling so well, they're having a little bit of bone pains, they're getting some recurrent infections, just kind of like what I call like a blasé sort of feeling. That's what as a French would say. And what I would do is that I would take a serum from this patient and do an actual immunoelectrophoresis on them. And I'd look for different spikes to see if any subset of antibody is out of whack. It's a technical term. So here's how this works. You have several different types of antibodies called immunoglobulin alpha. There's delta, there's mu, there is gamma, and there's epsilon. So IgA, IgE, IgD, IgM, IgG. These are different molecular structures, different types of antibodies. And now in multiple myeloma, there's always going to be one of those types that spikes very, very high. Now, the one that spikes the most is the gamma portion, is IgG. It's called a monoclonal gammopathy. That means that you have one clone of plasma cells. These are memory B cells that are constantly producing IgG through isotype switching. I think we talked a little bit about VDJ joining and somatic hypermutation as to how, in the germline DNA, how the actual molecule gets switched around and you're able to produce a different type of antibody. Some people actually get the alpha part too. They have IgA and IgG. Again, the most common is IgG. Now, why is that important? Now, clinically speaking, when you have these plasma cells that are creating a massive spike of basically junky antibodies, you are going to have deficiencies in different subtypes of these antibodies. And there's one called IgG2A. That is the type of monoclonal antibody that is specific against polysaccharides. In other words, Streptococcus pneumoniae, Mycoplasma pneumoniae, different types, any agents that are encapsulated that can cause a clinical pneumonia or a community-acquired pneumonia. That's what actually eventually this is what kills a lot of these patients, is that they develop a massive pneumonia that they cannot fight against. They are immunocompromised. And so I believe we have an image of a chest x-ray. If we can have a look at that.
All right, there you go.
Okay, well, and this is exactly what I was talking about. This is an infiltrative process. If you look at the chest x-ray, you'll see on both sides of the lung field here on the left and the right. Usually how we generally will read these chest x-rays, we have to look at the size of the diaphragm, see if there's any elevations. You have to look at the heart and see if that the cardiac silhouette is in the right place. But you also see there is, in fact, an infiltrative process here. And this tells you that this patient came in with pneumonia. And in fact, this is taken from a case of a patient having multiple myeloma who did unfortunately develop this adverse complication. And again, these are people that, even though in the older population, people tend to be a little bit immunocompromised, they go on the pneumovax vaccine and the influenza vaccine, they tend to still develop some pneumonias. These people are predominantly predisposed when compared to the general population. So that's why it's important to know this. Now, in fact, and I said earlier that I would dedicate part of the show to a dear family friend who did pass away from this, and his name is Robert Zipperstein is his name. And a gentleman that I've known since I was a child who's been very supportive of my life. And same thing, he went to the physician one day and they did a chest x-ray, they did a full workup, seemed fine. And literally within months, his entire clinical picture changed quite adversely.
And this was, and his age was in that
55.
55, so
55.
young.
He was young for the disease. They basically went ahead and did a stem cell transplant, which we'll talk a little bit about that a little bit later in the show. But the whole reason for doing that, obviously, is that if these plasma cells are taking over your bone marrow, you need to replace it in order to make sure that the building blocks for all the other cells in your body, and hematologically speaking, are going to work properly. So that this person went on melphalan and prednisone. Again, melphalan is an alkylating agent that is used for treating this disease. Prednisone is corticosteroid, and then you have basically all the other treatments that he underwent. And unfortunately, what actually did him in is that he went on a plane one day to see his daughter graduate from college. A lot of people were sick on there, and against his physician's secondary infection, because being in a cabin where, in an airplane where the air is filtered through everything, you're more prone to getting pneumonia, and eventually that's what he came to. So.
Now, at this point, since we're starting to talk a little bit about diagnosis, I know that there's symptomatic myeloma and there's also asymptomatic myeloma.
Correct.
And can you differentiate between those? What
we're talking about is something called a monoclonal gammopathy of unknown significance. It's called MGUS. That means that there are some people that when they get older, they just happen to have plasma cells in their body that produce a little bit more of antibody than usual. But clinically speaking, they don't really have that much to look at. Their sedimentation rate may go up a little bit. It's called an ESR. That will go up, and maybe their vision may change a little bit. They may feel a little bit lethargic. They're a little bit low in energy. But ultimately, that's not going to be fatal. So it's true that I've also had patients that would come into clinic, and I would draw their blood. We get an electrophoresis done, and you see there's a little bit of a gamma spike on there. But clinically, they'd be fine. They wouldn't have any anemia. They wouldn't have any secondary infections. Their calcium level is normal. But at the same time, you still have to watch those patients very closely because it can always turn into multiple myeloma, and you know there's already a predisposition for that. So that's true, that there are asymptomatic versions of this.
Can you talk a little bit about a related condition, which is solitary plasmacytoma?
It's more or less the same condition. We're talking about you have a set of plasma cells that are out of control, that are producing the same clinical symptoms. That disease is a little bit more specific, probably not seen too much clinically, but it is still within the same genre of multiple myeloma.
So let's talk some about your diagnosis. You have a patient who's come in. You mentioned that you see folks. They come in to the clinic and you begin to work them up. And well, it sounds like we're actually going to go to a commercial break here. If you'll hold on 1 second,
absolutely.
Stay with us. I'm Dr. Jonas Moses. This hour you're watching On the Edge, Conversations in Internal Medicine. We'll be right back.
It is our goal to improve patient care through the methods of preventative medicine. At the same time, we try to relieve the economic stress that physicians are faced with every day through consistent, increased reimbursement. The ANS is the vital sign driving all other vital signs. It differentiates individual response to disease, therapy, and lifestyle. You are already treating your patient's ANS. Now you can scientifically optimize therapy for the individual patient. Now the effects of both branches of the ANS can be visualized quantitatively. ANS testing is recommended as a standard of care by the leading medical association. ANSAR is the standard of care in ANS monitoring. Cardiovascular autonomic neuropathy, or CAN, is a silent killer claiming the lives of 25 to 50% of patients within the 5 to 10 years after symptoms first appear. CAN is recognized as progressive dysfunction of the ANS. If ANS dysfunction is identified early with proper intervention, CAN is preventable. You may be asking yourself, why haven't I heard much about ANS dysfunction and CAN before today? This is because ANS dysfunction is asymptomatic, and until the development of ANSAR's technology, ANS dysfunction could not be observed or detected until end organ damage or neuropathy has already occurred. You can start treating the cause, not just the symptoms. If you would like more information about ANSAR and the ANX 3.0, please feel free to contact us at 888-883-7804.
Two words for you. Pop quiz. Ready? Name any funny movie. A drama. Name a mystery. And one more thing. Name the movie your kids saw today in science class.
Know what really matters. Know about your kid's school. And know about your kid. Find out 100 ways to know more, do more.
Thank you for staying with us this hour on The Edge. If you're watching the program live, it is a Saturday and you're watching between noon and 1 Central Standard Time in the United States or elsewhere in North America. And I want to remind you that if you are watching live, you can join the conversation this hour by sending an email to ask@endtimetv.com. That's ask@endtimetv.com. Someone is monitoring that mailbox, and any questions, comments you have, you're welcome to join us. Also, should you be watching this show as it's rebroadcast, aired either over Endtime TV, www.endtimetv.com, or recent postings. I've been posting all of these shows as well on a website called YouTube. If you happen to see one of the shows either way, and it's archived or on demand, you can still send emails to ask@endtimetv.com, and we will follow up on those in the next live session. Just as we were in the commercial break, I happened to ask you a little bit about staging, the international staging system, and I did want to speak to that just a little bit before we move on, and just point out, and you can help me with the science behind this.
Sure.
There is an international staging system, ISS, for myeloma, and it was published by the International Myeloma Working Group in 2005. Stage 1 is beta 2 microglobulin B, or beta 2M, and that's less than 3.5 milligrams per liter of albumin, greater than or equal to 3.5 grams per deciliter. Stage 2 is beta 2M, less than 3.5, and albumin, less than 3.5, or beta 2M, greater than or equal to 3.5, and less than 5.5. And stage 3 is beta 2M greater than or equal to 5.5. And then there's the Dury-Selman staging system, first published in 1975. The Dury-Selman staging system is still in use, but is largely being superseded by the simpler ISS, and that system I won't go into in great detail, but just to point out that it's a little more elaborate baseline.
Right.
And stages 1, 2, and 3 of the Dury-Selman staging system can be divided into A or B types depending on serum creatinine. And I'll ask you a little bit about why that's important.
Right.
So if you want to speak to that, I would love to have a little more input for our viewers.
Well, the important thing to know in terms of staging, and actually it's interesting, when you showed me the staging, I jogged the old memory back. The beta 2 microglobulin, why is that important in staging? We have to remember what beta 2 microglobulin actually is. And actually, this is really important when we talk about things like renal failure and, as you mentioned, about the creatinine level, because that's the index for measuring how functional the kidney is. Now, beta 2 microglobulin is a functional part of something called the major histocompatibility complex type 1. If you remember before that we talked about the immune system and how there's two different branches to that. One is the cell-mediated portion. The other half is the humoral portion, or the antibody-mediated portion that requires type 2 MHC for antigen presentation and for creating the plasma cells, and that's the target of interest for this conversation is about multiple myeloma. Now, the beta 2 microglobulin portion is class 1, so that's the part of the complex that deals with cell-mediated immunity.
Okay.
Now, why do we check that? Because, remember, in any kind of cancer, you're going to have massive turnover of cells, especially when it comes to oncology and to hematology. Remember, we discussed blood dyscrasias before. Well, a lot of times if a red blood cell is not functional, it's always going to be lysing products into the bloodstream and things like that. Well, here you have immune cells that are constantly turning over, dying, being created again, and what's going to happen is that this is how you get this soluble portion of MHC1 into the bloodstream. Okay, why is it actually beta 2 microglobulin really important? Is that even in patients who have dialysis, we watch the beta 2 microglobulin level, because when you filter the blood through the system, you actually will get small breakdowns of the cells. Because remember, whenever you take blood out of the body and put it back in, that's always going to be an irritant on the system. And when you have beta 2 microglobulin being always secreted, you always hear about patients who are on dialysis who get a carpal tunnel, and their tips of their fingers are very numb. And a lot of times that's because you actually get an accumulation of the beta 2 microglobulin in the carpal tunnel portion here, where you have compression on the median nerve, and that's what ends up happening.
And this is an interference with circulation?
Not with circulation, but you're actually getting deposition of beta 2 microglobulin, again, that part of the molecule that has to do with cell-mediated immunity that gets secreted. You'll actually get accumulations of this molecule, and it'll go into places that can cause signs of neuropathy and whatnot. Now, that's first thing. So second thing is that why is the creatinine important? Because remember what we talked about in the first portion of the show, how horrible this disease really is on your kidneys. It creates havoc on your kidneys. You have problems in terms of glomerulonephritis because you have a type 3 hypersensitivity reaction occurring, because you have an antigen-antibody complex that's going right to the basal membrane of the kidney, causing acute renal failure. You have hypercalcemia that makes the kidneys function even less. And it's because of those, and especially when you go into treatment options, which we'll talk about later, some of them can be nephrotoxic. So you combine all those together, and that tells you what the prognosis is. And a lot of times, if a patient comes in, usually a baseline creatinine for a healthy person is going to be about 0.9 or 1.0. These patients come in, they're 2.5, 3.0, and beyond, and they will go into acute renal failure, eventually possibly chronic renal failure, and will require dialysis. And that's what makes the monitoring of this disease so critical, is because if your kidneys are not going to be functional, that's going to wreak havoc on the rest of the body. So,
okay, thank you for addressing that. We did want to talk a little bit about some therapies, and at the beginning of the show, you had brought up thalidomide, and I wanted to talk a little bit more about it. It's true that back in the 1960s, there were some serious birth defects related to this.
Right.
And can you talk a little bit about what the benefit is? Plainly, it's something that has to be very carefully monitored. It's under certain circumstances then very toxic to the fetus.
Right. Well, again, that we're assuming that we're treating a pregnant woman, and again, this disease is more prevalent in older people, generally more prevalent in males. So it's not that. The reason why I mentioned that before is because it had such publicity back in the 60s. If you read back on what was actually making headlines back then. And
by the way, it wasn't used for this disease in the 1960s.
Right. No, it was not. It was not. I believe it was for joint problems and things like that. The women used it for those, and the children would have what's called like a short limb syndrome, where obviously a normal length this far, we were talking about maybe around close to the antecubital fossa, so right around here is where these patients would have limb anomalies. Now, the other issue is that we have to decide therapeutically what is going to be used. Now, we have a structure of thalidomide to show on a slide here, if we can take a look at that.
All right. There it is.
There you go. So, again, the little structure of thalidomide. And actually, we have another diagram that shows the actual mechanism of action of that, if we can go to the next slide.
Well, we're going to go take a commercial break, and we'll pick
we'll
up
get back to
when
that.
we come back. Stay with us. You are watching On the Edge, Conversations in Internal Medicine. This hour, we are talking about multiple myeloma. I'm Dr. Jonas Moses. With me, Dr. Doron Feinsilber.
It's easy to tell if you've had way too many. But what if you've had just one too many? Buzz driving is drunk driving.
Hey guys, thanks for coming.
Are we in trouble?
No, you're not in trouble. I just want to set some ground rules.
Like what?
Well, remember last week when you hit Vinny in the head with the shovel?
I do not recall that.
Of course not. Well, it was pretty graphic. Too graphic for the kids. So I'm going to have to block you.
I got to make this up to you. This is Vinny's watch, and I want you to have it. You deserve it.
No, thank you. That's really not necessary.
No. Come here.
Welcome back to On the Edge, Conversations in Internal Medicine. I'm Dr. Jonas Moses. With me this hour, Dr. Doron Feinsilber. We are talking about multiple myeloma this hour. And just as we were entering the commercial break, we had started talking a little bit about thalidomide. And I believe that we have a slide. Let's see if we can get that up here. There you go. I don't know, is that clear enough to appreciate?
Came in a little bit fuzzy there, but I can, well.
What we're looking at here is the action of the drug.
Yeah. Well, I essentially, I can just give a little bit of an idea about what it does. Is that, if you remember what we talked about, that the synergistic cytokine regulation, so we talked about interleukin-1, interleukin-6, and tumor necrosis factor alpha. Those three combined create a lot of the clinical symptoms that we see, like the hypercalcemia, and again, 'cause, we also do a lot of times what's called a skeletal survey, and that's going to tell us really what how far the disease has actually progressed. What thalidomide actually does is that it will interfere with TNF alpha. It blocks it. When it blocks it, it means that you're decreasing the synergistic effects of the other two cytokines and creating a better clinical picture in an ideal world, of course. That's why. Remember, one will not function without the other in terms of pathogenesis. You can't have IL-1 alone creating hypercalcemia. You can't have IL-6 alone creating hypercalcemia, but the combination of the two will cause that. And so TNF alpha is what contributes to that, partially. So that's what we use it. But now, some of the other standard therapies that we will use are things like melphalan and prednisone. Melphalan is an alkylating agent. That's what's used for chemotherapeutic reasons.
Prednisone is obviously a steroid.
The steroid, right? And a lot of times we usually get like a baseline bone mineral density to make sure that if they need to have other types of therapies involved, to make sure their bone density doesn't go down. That's really important because remember, these are older patients. And imagine if someone develops osteoporosis from chronic steroid use and they're in a nursing home, they're more prone to having hip fractures or things like that, especially if they're living at home and if they don't have a home health care nurse. That can be very dangerous. So a lot of times patients, again, will die from secondary causes of this disease. They may actually fracture a bone, have to go into orthopedic surgery. They may have a pulmonary embolism because they're immobilized. They may have the hypercalcemia from the multiple myeloma occurring. They may develop a community-acquired pneumonia from either being immunocompromised or even being immobile and not being able to fend for themselves. So that's another issue that has to be discussed. But
I want to go back to the workup for just a second. You mentioned a skeletal survey, and this is a series of X-rays of the skull, the axial skeleton, the proximal long bones. Right. And myeloma activity sometimes appears as lytic lesions with local disappearance of normal bone due to resorption. Right. And in the skull X-ray, it's a punched-out lesion. It's called a pepper pot skull.
We always call it a punched-out lesion in the clinic, but same difference.
And magnetic resonance MRI is more sensitive than simple X-ray in the detection of lytic lesions, and may supersede the skeletal survey, especially when vertebral disease is suspected. Occasionally, they also use CT scan.
They can, or even a bone scan, which requires a technetium-99m with the MDP.
And you also perform a bone marrow biopsy, I believe?
You can.
Okay.
I can talk a little bit about that. It's not a very pleasant procedure for a lot of patients, and of course, I've only done 2 of them myself. Of course, under some supervision because that's how you learn. But essentially, what happens then is that we can't really diagnose the disease fully. I mean, of course, there's lots of diagnostic criteria, some non-specific, like the hypercalcemia, the renal function. These are all simple blood tests. And you may have like a monoclonal gammopathy spike on serum electrophoresis. But to definitively diagnose it, you have to actually take a bone marrow biopsy, fix slides, make a smear, and then the pathologist will call and tell you what's going on. The bone marrow biopsy itself requires the patient to lie on the lateral side, and essentially what you do is you have to drape the patient, and of course everything's done under sterile conditions, and then you actually have to get to the iliac crest, and so we're talking about the level of L4, L5, and try to actually take a long gauge needle. And again, under general, not actually general anesthesia, but I'd inject lidocaine peripherally, and I would eventually create almost like a borehole in the iliac crest, and in fact, I actually have to take some bone out in order to get to the marrow itself. So you actually hear a little bit of almost like a crunching sound. Again, not very pleasant for the patient. I generally give them a little bit of Ativan before just to calm them down. It's a benzodiazepine, so they'll just be a little more relaxed. And then eventually, when I am able to get enough sample, then I will, obviously cover up the wound and go from there. But again, not a very pleasant experience, but also a very necessary one in terms of clinical management, because you want to make sure that this is really what you're treating. So when you look at this smear on the slide, you'll actually see these predominance of plasma cells, and it actually looks very obvious. It's not, most general internal medicine docs or pathologists will be able to tell that within moments of looking at the slide. So that's important to do.
So let's get back to some other therapeutics. What are some other treatments that are used that have any kind of success in slowing down this process or causing remission?
Well, there is a humanized monoclonal antibody that's been produced called bortezomib. I always pronounce it the wrong way. But that's been used a little bit more frequently now. Still, again, there's a little bit of experimental therapy. That's usually what you're going to use after melphalan, prednisone, and a possible stem cell transplant, depending on what the staging of the disease actually is at the time. So that's one of those therapies that, of course, is
bortezomib it's a proteasome inhibitor.
Proteasome inhibitor, correct? Right.
Can you and I also come across Revlimid, where it's a lenalidomide.
I don't think I've ever heard of that.
Right. It's apparently a less toxic thalidomide analog.
Okay.
So I don't know much more about that. Perhaps someone in our audience can share more information with us about that. Renal failure that you've brought up is there are two different kinds of renal failure: reversible and non-reversible. Correct?
And there's also acute and chronic as well.
Right.
So acute is something that's going to happen in a case where a person normally has a very healthy kidney, and it happens more suddenly. Chronic means this person has a disease that's been going on for years and years, and usually requiring dialysis. And
we're going to a commercial break. We'll pick up where we left off. Stay with us. You're watching On the Edge, Conversations in Internal Medicine. This hour we are talking about multiple myeloma. I'm Dr. Jonas Moses. With me, Dr. Doron Feinsilber.
Family and friends can provide the support you need to reduce your risk of cancer, diabetes, heart disease, and stroke. Eat right and get active.
Impossible.
It's never too early to start reading to your kids.
Are you prepared for what awaits you?
There are amazing possibilities when you open a child's mind to reading. Log on to the Library of Congress website and let the journey begin.
Thank you for staying with us this hour of On the Edge, Conversations in Internal Medicine. I'm Dr. Jonas Moses. This hour we have been talking about multiple myeloma. My guest and regular contributor at this point, a special correspondent, Dr. Doron Feinsilber in internal medicine. And during the commercial break, we were talking about the Multiple Myeloma Foundation, and I wonder if you could speak a little more directly to that.
Sure. Well, like I said earlier in the show, the most important thing after talking about the biochemistry, about the pathophysiology, about treatments, therapies, is really the humanistic end. And again, I personally knew somebody who did pass away from this, and it was not a very easy death for this person as well. He was very strong, and he fought quite a bit, all the way to the end. And is I really have to say that his family is very blessed to have had such a strong and loving person like that. Bob was really a phenomenal human being, and I think once I saw how horrible of a disease that really was, I started looking at the literature and seeing that there isn't a multiple myeloma foundation that's out there that does help families, that does talk about what it's like to have a loved one with this disease, and how the support network that's out there. And I was really surprised. I mean, the network itself is amazing. They do have several fundraisers throughout the year, and like I said, you can subscribe to newsletters, and they have online chats and a lot of different group events a lot of times that I think are wonderful, and I think we should have a...
Do we have a slide of that foundation? I don't know if we do.
I don't know if we have one up or not, but I would. I think
perhaps in a second we will. But
sure.
In the meantime, I'm confident that you can go to the internet and do a search on Multiple Myeloma Foundation, and you'll come up with a website.
Yes.
And do they directly engage in research, or are they merely supporting research organizations?
Well, they do a lot of fundraising for research.
Okay.
And there is quite a lot of it done, especially at the NIH and Bethesda and other institutions of higher learning. They do tend to do that a lot. But like I said, I mean, what I think is really important here is that at least it creates a forum for people who are stricken with this disease or have loved ones who are stricken with this disease that can have a little bit of solace in understanding what's going on. You know, I remember that when I found out that Bob had multiple myeloma, you know, I was just barely in high school, and I didn't really have a conceptual understanding as to what was happening with him. Except all I know is that when I saw him a couple times later when he came to our family's home, that he looked much worse. He lost a lot of weight. He was very agitated. Even his mental status changed quite a bit.
So there's a dramatic change in this disease process.
Right.
And I'm curious to know if the foundation is engaged as well in fundamental, I don't know, conversations, education, continuing education for people who are trying to understand more in depth the process of multiple myeloma, as we've had on this conversation here.
Well,
do they provide access to that kind of information as well?
Well, you have to keep in mind that it depends on the patient who has the disease. It depends also on how well informed they are. I mean, I'm sure during this discussion we probably threw out a lot of terminology that most people probably wouldn't understand.
The public might not.
Right, exactly. Right. So you have to kind of keep in mind that, you know, and this is also important for me as a physician too, is that I am used to speaking to several colleagues about several diseases, and there's a certain vocabulary that you develop when you're already in the field. So, and it really is its own language in a lot of ways. And so a lot of times I have to remind myself that when I'm treating another person, that those people are really at the same level that I was at when I was in high school, hearing about my our family friend who's passing away from it. So you don't want to be left in the dark, and I think that it helps me guide how I speak to patients and how I, on a social level, conduct myself when it comes to that. Because, again, this is a very real disease. You know, they have their loved ones who can potentially pass away, and probably not in the nicest of circumstances. And it does emotionally help if they can understand on an intellectual level what's happening. So, and I think that foundations like that tend to do that quite a bit.
Well, and I guess I bring this up because that's an aside to those among our viewers who are involved with foundations, who are involved as physicians in clinical patient care,
right,
to be certain that we don't obfuscate or we don't use too much jargon. As I always ask in our conversations, that we define our terms, that we make certain that the broadest possible audience has access to this information. And kind of a caveat out there is you're thinking about how to present information to your patient population, to other people who are not necessarily a part of the underlying scientific medical conversations.
Right.
I am so thrilled to have had you as an asset to On the Edge.
It's been a pleasure,
Jonas. Year. And it is with not a little bit of excitement that I wish you well in your new adventures out in Baltimore, and I look forward to continued conversations long distance. We'll figure out technology ways to have you join the conversation. I do want to remind everyone that you can join this conversation on a regular basis, whether you're watching live or you're watching archived or on-demand programming, that you can go to ask@endtimetv.com. You can send an email to ask@endtimetv.com and join the conversation, ask questions, make comments. You can also visit my blog site. That's jonasmoses.blogspot.com. jonasmoses.blogspot.com, and any commentary you have there, I always welcome that, of course. And as I mentioned, I have begun posting segments of archived shows, or as we call it here, on-demand shows, on YouTube. That is www.youtube.com. And all you need to do is search for Jonas Moses or On the Edge, and you'll find about, I guess at this point, about 70 different segments airing. Remember that you are watching On the Edge at InTime TV. That's www.intimetv.com. And this hour we have been talking to Dr. Doron Feinsilber, an internal medicine specialist, and we've been talking about multiple myeloma. For On the Edge and for InTime TV here, I am Dr. Jonas Moses, and I wish you well. I hope that you're able to join us next week. I have a special report on public health policy. I think this is going to be an incredibly important show, and please tune into that. We'll have some extraordinary guests and a very, I would say, controversial conversation presented. Again, Dr. Jonas Moses, On the Edge.